Hi, good evening and welcome. Thank you for joining the third webinar in our series on CAR T-cell therapies, exploring CAR T-cell therapy during the COVID-19 pandemic, mitigation and management of adverse events. I'm your moderator, Daria Zangari, Scientific Director for OncLive, and I'm very happy to be here with all of you tonight. The mission of this webinar is to provide our listeners with expert insights on relevant topics in today's cancer care and treatment. We will cover a list of topics that our panel will go into greater detail on, sharing their insights from the front lines. So tonight's topics of discussion, we will be discussing the CAR T-cell experience, some real-world experiences with bridging therapies, and strategies for adverse event management. If you're listening to this webinar, we encourage you to submit your questions, and we will try to answer as many of them as we can during the Q&A portion of this webinar. So thank you for joining us, and thank you to our faculty for being here. So joining us for week 3, we have our faculty panel. I'll ask each of them to introduce themselves and give their title, affiliation, and a little bit about their practice backgrounds. So Dr. Nascabo, we'll start with you.
Yes, thank you. I appreciate everyone being with us. If you're joining us for the third week, you will remember I'm Loretta Nascabo from the University of Texas, MD Anderson Cancer Center in Houston, Texas, in the Department of Lymphoma Myeloma.
Great, thank you. And Dr. Lunning?
Matt Lunning, University of Nebraska Medical Center here in Omaha, Nebraska. I specialize in lymphoma and cellular therapy.
Thank you. And Dr. Galal?
Ahmed Galal from Duke University, Durham, North Carolina. I'm a professor of medicine, and I see only lymphoma and CAR T.
Great, thank you. So as most of you know, they've been with us for 3 weeks now, so we're excited to have them back again and to get this week started. So we'll just start out with going over some of the numbers. We'll take a quick look. So what has occurred over the past weeks? So currently, there are 5.5 million global confirmed cases with over 1.7 million in the United States. So unfortunately, the numbers continue to rise. And in many areas, precautionary measures remain in effect. Many states have begun loosening the restrictions and entering the various phases of reopening. So that really is varying from coast to coast and the different regions. Cancer centers and institutions, they've allowed for re-entry and are resuming day-to-day operations. However, you know, these day-to-day operations are looking different than they used to look. So let me just start out with asking our panel, what has changed at your institution since we spoke last week? So have there been any updates or challenges since the last time that we spoke? So Dr. Lunning, I'll pose this question to you, and then I will ask our other two faculty.
Not much has changed in the last week, other than the weather. It was a rainy and gloomy kind of weekend and holiday weekend. I think it's opening up a bit more. I was pleased when I went and bought flowers on Saturday morning that I bet 90% of the people that I saw were wearing masks entering the grocery store.
Great. Yep. And there was a lot of people wearing masks around here too. So that's we're reopening in the East Coast as well. Dr. Nascabo?
The major change for us is that we're about 90% capacity right now with our clinic volume. So learning how to practice with social distancing, particularly in our waiting rooms, is a new era for us.
Great. Thank you. And Dr. Galal?
Not much has changed from last week, except we're opening more people coming in. The parking went back to be crazy as usual. But really, the volume is much higher than before. So we're slowly going back to normal.
Great. Thank you. So to recap for our audience, in the previous weeks, we've talked about the impact of COVID on cellular therapeutics and some of the real-world data that we have seen with the available therapies. So this week, our panel is going to navigate through real-life patient cases, so we have 2 of them, to provide their perspectives and some of their institutional processes surrounding the management of these patients. So we will have Dr. Galal navigating through these cases, and we'll have our other faculty commenting on them as well. So Dr. Galal, I'll hand this section over to you.
Thank you. This case number 1 is 48-year-old female diagnosed with leg-type diffuse large B-cell lymphoma in May of 2019. She completed actually 6 cycles of our EPOC in November 2019, had a PET scan afterwards, and it showed really complete remission with Deauville 2. At the end of December, beginning of 2020, she started to have night sweats, fever, returned to basically initial presentation that she had when she presented back in May. Subsequent PET scan did show recurrence of her lymphoma with a Deauville 5 score. There are also the skin lesion, which is typical for the leg type, and these got worse than before. Sorry, I'm turning, here we go. So basically, this is the base of the slide and of the case, and then we can go over some of the stuff that we can talk about. Did I miss a slide here, or? I think I did. No. Okay, sorry. So basically, if this patient did not have any response to the frontline therapy or relapsed really shortly after that, what would be the chances of her going into complete remission with subsequent chemotherapy or chemoimmunotherapy? I think I put that question out to my colleagues, and we can discuss a little bit.
So I'll jump right in there. Based off of the CORAL study, we know that patients who progress within 12 months of frontline rituximab and CHOP-like therapy, there's only about a 20% chance that they're going to have a meaningful outcome with salvage chemo followed by high-dose therapy auto transplant. So I think the biggest concern I have for this patient, in addition to having the leg type, which can be a more high risk, though rare subtype of large cell lymphoma, is that though she achieved a complete response, within 2 months of achieving that complete response, she's showing signs of disease progression. And so if I were having that conversation with her in clinic, I'd say there's probably only about a 20% chance that we'll be able to salvage this with salvage chemo followed by high-dose therapy auto transplant.
Yeah, I think a point to note is that in some of our second-line randomized trials, you have to look at the measure of how a response was obtained. And so we're kind of in a different era now with the Deauville score with regards to defining CRs. So when you refer back to some of the, like the Canadian CIC study, LY12, as well as Orchard, and even as you referenced back into CORAL, those numbers often may not reflect the modern response criteria.
So if this patient went into, if this patient goes into complete remission, would you send her to auto transplant?
My preference for this patient would be to try and, So my preference for her would be to enroll her on one of those randomized studies that are taking these high-risk patients, and they get randomized to either salvage chemo or CAR T at second line. Recognizing for the folks that don't have that option, or if she's not a candidate for that trial, I would attempt salvage chemotherapy. And if she achieves a complete response on PET, as Matt just mentioned, we're kind of practicing outside of what the prospective data might tell us. But those are the patients I feel relatively confident about going forward with high-dose therapy auto transplant. If she fails to achieve a CR, though, I struggle with those patients, and I'm less confident that the side effects of high-dose therapy are going to be worthwhile.
Yeah, I would agree. If this person goes into a CR with second-line therapy, and if it's a true PET CR, then I would offer her consolidated transplant.
So that's a nice segue to the next question, which basically, if she's in PR, would you take her to transplant versus CAR T? I think Matthew raised that point, and you might want to start with that.
Yeah, so I think that there, in the Deauville criteria, there are PRs, and then there are essentially what I call very good PRs. Not to borrow from our myeloma colleagues, but in the era of PET, you have to meet several criteria in not only lymph node size, but also reduction in avidity. And so there are the PRs that, barely meet 50% reduction in nodal size and target lesions. And, the delta SUV is, went from 13 to 6, if you will, so still above liver background. And then there are those that, go from 24 to 4, and their nodal size, have reduced by 90%, but they don't quite get there based upon avidity. So, that's those two scenarios, both could be considered, PRs. I feel way more comfortable taking, a very good PR by PET CT, even if it's a residual, lymph node. Then I have a plan. I would consolidate that person and probably give them post-transplant radiation to that solitary site or any sites that were previously bulky. And it's often those bulky sites that are hard to get down to a quote unquote a Deauville CR from that standpoint. And so I haven't seen good data on this. I know that there's data, from single institution data from Memorial. There's also CIMTR data looking at PRs, but I'm just not sure in the modern response criteria that all PRs are created equal.
Loretta, what do you think?
I completely agree with that. And I think prior to having CAR T in our toolkit, I was more inclined to take those PRs to transplant. Now that I have something that I know if they have adequate disease control and they're in a low tumor burden state, I've been considering CAR T for those PRs. As Matt mentioned, not all PRs are PRs, but those that are even pretty good in terms of reduction. If we're not there to CR, I know I have an alternative therapy that I didn't have 2 years ago.
So this lady actually went through 2 cycles of rice, and we did a PET scan afterwards that showed disease progression with the VAL5. So we're back to square one. At this point, what would be your preference to do in this day and age?
This is a scenario that really bothers me, clinically right now. While it is the minority of the outcomes of diffuse large B-cell lymphoma, as you pointed out, the leg types, the CD5 positive large cells, the double hits, even if they've gotten dose-adjusted EPOCH-R, you kind of are hesitating, in these primary progressive lymphomas to give them, second-line therapy. I've often argued to look after 1 cycle because I get kind of concerned that if they're double refractory, that you may be missing the window to get them to CAR T-cell therapy, which is, I think, where I'd be heading with this individual. And I would have already started kind of putting the bug in the ear about CAR T-cell, and also having our financial people start to look in kind of how difficult do they think it's going to be while they're doing their checking their transplant benefits, potentially even checking their CAR T-cell benefits.
Loretta?
I think what we're missing a little bit is sort of a description of how much tumor burden this patient has. You have in this next bullet point that this patient is stable. So again, I think there is a sort of proliferation rate of the tumor that also guides me in terms of, should I try an additional line of therapy to try and cool this patient off, per se, while we're dealing with the logistics of getting CAR T approved and undergoing manufacturing. Recognizing, and we'll have this discussion, that how do you choose a third-line therapy that's going to be more effective than your first two? Again, 2 years ago, that was a much more challenging discussion than now, and I anticipate there'll be even more drugs available, which makes our job a little bit easier. But I do think that looking at the actual scans to see how much tumor burden is there, following things like LDH, B symptoms, and performance status can help guide you in terms of what your immediate next step needs to be.
Great. So this patient basically was referred to us after the first line failed, and she was getting the rice, and basically we anticipated that she's not going to be responding well to rice, and the PET scan showed that. So she was assessed for CAR T, got financial approval, and she went actually through CAR T. She was stable in general, so we didn't do any bridging chemotherapy. So her post-CAR T course was complicated by grade 1 neurotoxicity, which did not need any management there. She was discharged 10 days after the infusion to the outpatient clinic. And basically, the day 30 PET scan showed PR, and day 90 showed disease progression with the VAL5 score. Now, my first kind of point is how many patients with PR at day 30 might sort of convert into a CR? Loretta?
So it depends on what you look at, but maybe as high as 30% of patients will convert from a PR to CR from that day 30 to month 3. We've heard and have seen rare reports of even responses beyond the 3-month assessment, but again, those are quite rare. I think the most anxiety-provoking situation I'm in is when I'm looking at a day 30 response and it's not a PR. But as Matt mentioned earlier, there are dramatic responses that don't quite meet the definition of CR and those that barely make that 50% reduction. So I think the ones I'm most confident might convert from a PR to CR are those that have been very dramatic. And what I think is still showing up on that PET scan is just some post-treatment inflammatory changes and maybe not refractory disease. But what I always tell patients at that time point is we will know quite rapidly, generally speaking, if they're going to convert or they're going to progress.
We've kind of went away from the day 29 PET CT and really, kind of case by case basis, we're getting them before kind of a day 90, day 100, kind of following a little bit more of an auto paradigm. That being said, if I know a person's going with a lot of tumor burden, I'm, like an eagle on their LDH and their symptoms to kind of looking early, because I think, if they're progressing after CAR T cell, you want to be catching it early because you have to be thinking about what that next line of therapy is going to be.
Okay, well, actually, in our institution, we still do day 30 and day 90 PET scans. We're really happy if everything is clear, so we wanted to see that. Now, she relapsed actually post-CAR T on the day 90 PET scan, and in terms of recommendations post-CAR T treatment, what you guys do in your institution? So, Loretta, what do you do with this kind of case?
So I think all these patients should be offered a clinical trial, but even at a center where that's our first priority, it's been very challenging for a number of reasons. Oftentimes their performance status is very poor. They may have persistent cytopenias. So particularly between that day 30 and 90, finding a patient that's a suitable candidate for trial has been challenging. There was some data presented at ASH this year looking at the bispecific antibody mosunetuzumab with, again, small number of patients, but showing some activity for CD20, CD3 targeting therapy post-CAR T cell failure. We have a trial currently looking at a checkpoint inhibitor in combination with lenalidomide, despite some of the toxicity that's been reported in myeloma, but that might be one strategy. I think where we struggle the most is those that are actually CD19 positive, trying to identify why they failed, and do you try and challenge them again with another CAR T cell infusion? Do you try immune therapy, or do you move away from it altogether? And then the CD19 negatives, in some ways, to me, is a little bit easier, because then it reduces some of my concern about should I try sort of revving up that immune therapy approach.
I agree. I think that clinical trials would be an option. I think that, there is, not in this case because of how early, but, one of the questions that's out there is retreatment of CAR T cell and the price tag that goes kind of along with that, but also kind of the CAR, I know we're likely talk about this next week, but the next generation of CARs, kind of where will those fit in? And I think that that's an opportunity for some of these CAR T cells to kind of get dip their toes in the water as those people who have counts that didn't have significant toxicities to retry a different mechanism of CAR, whether or not it's a 1922 or 1920 or a completely different mechanism of a CAR T. But just writing these CAR T cell failures off and not allowing them to be on a clinical trial that's a CAR T cell is just, in my opinion, not right. Granted, I agree with you, taking a person to a checkpoint plus lenalidomide CAR T cell would be reasonable, or a checkpoint would be reasonable, or lenalidomide single agent, depending on certain situations, what their counts are and their eligibility but just excluding people from trials because they've had a prior CAR T, I just don't agree with.
So I'm going to take you a little bit back to the CAR T approval process, and I'm going to ask you, in your institution, how difficult to get somebody with good insurance and to get approved for CAR T, and how difficult is it for Medicare patients to get approved?
So good insurance, I assume we mean privately insured, and it depends on if whether or not we've ever had a prior approval with that type of insurance within our institution. Because if we've had, oftentimes we can revisit the contract language that was used and approved by that insurer. And we also have a sense of the timeline and recognizing that it's gotten much better. But even right now, I'm sitting on a case that we know that this insurance is going to be somewhat challenging based off of our last experience, which took about 3 weeks. So that's helpful to me because we'll discuss this, but what do I do for this patient if I anticipate a 1 to 3 week window where I'm still waiting on approval before I can even proceed with leukapheresis? At our center, currently, Medicare is easier for approval, recognizing that there are a number of centers that financially that doesn't make sense to move forward with Medicare patients, at least based off of inpatient management. But currently, we routinely get approvals to move forward with Medicare patients within a week.
So I referenced this in some data last week that I presented from my own institution, and I would think that Medicare is just as good as private insurance in the CAR T-cell space, from getting a patient from wanting to do the CAR T-cell to apheresis. But I totally agree with Loretta that I'm kind of talking to our financial people and kind of getting their opinion, because that helps me decide how many numbers of therapy, and not only if I'm going to give one, but before apheresis, what is that one regimen that I'm going to give? There isn't a lot of data to say that you shouldn't be, giving some regimen, but I think there's a lot of concern about some of the therapies and the health of the T cell, and whether or not you're going to get too lymphotoxic of a regimen that you can't manufacture CAR T cells after giving one cycle of what isn't really bridging. It's like pre-bridging to the bridge and then to bridge, even if you don't switch it. So, I think that that's part of the mix too. That wasn't, of relevance in clinical trials, but is certainly of relevance in the kind of the commercial environment.
Great. So in terms of workup for CAR T patients prior to their infusion, I'm sure every institution has a little bit of differences. For instance, we don't do any PET scans prior to the CAR T right away or after the lymphodepleting chemotherapy if they didn't receive any bridging chemotherapy. What's the status in your institution as a workup for these patients?
So we generally do have some form of imaging prior to leukapheresis, but as you mentioned, not between lymphocyte depleting and CAR T infusion unless there's some dramatic change in a patient's status that would warrant imaging. In terms of our standard workup, we do request brain imaging. We prefer brain MRI, but sometimes we are only getting head CTs in these patients so that we have a good baseline to compare to if neurotoxicity were to develop. We also will perform echocardiograms in these patients to try and identify those patients who may have difficulty tolerating or have the necessary cardiopulmonary reserve if they were to develop pretty severe cytokine release syndrome. Oftentimes, these patients have also had pulmonary function tests done at some point along the way. So again, to try and measure what their pulmonary reserve is prior to going into this, though we've not held up CAR T-cell infusions if that is missing in terms of their prior workup. Oftentimes, they'll have EKGs and lab assessments to look at kidney and liver function as well.
Matt?
Yeah, I would say the same, plus minus brain MRI imaging. I think still at our institution it's symptom directed. I think that there is. It's nice to have a baseline if you're kind of going into the thinking that a patient is high risk for neurotoxicity, but we haven't mandated it.
Yeah, so we have the same about the MRI. We actually don't get an MRI unless there are history of CNS involvement or symptoms to make you suspicious of that. So the MRI is case-by-case kind of approach. Now, any preference for lymphodepleting chemotherapy or any change in the type of CAR T if you want to do different lymphodepleting chemotherapy?
Generally, at our institution, we're following what was done in both the Zuma 1 or the Juliet study. I recognize that with the phase 1 that was published from UPenn, there was a variety of lymphodepleting that was done. And in some patients, having had pretty significant anti-lymphoma treatment did not have a prescribed lymphodepletion. But generally what we're doing is the Flu-Cy as was dosed in the pivotal studies.
Yeah, I have not given bendamustine or no lymphodepleting chemotherapy.
Yeah, I've used bendamustine basically in somebody that shortly relapsed after autologous stem cell transplant with a very tenuous bone marrow reserve. Therefore, we had to use that. We didn't want to sort of build up on the cytopenia. What about the manufacturing? Anyone had a situation where manufacturing failed? And if it does, what you do from there?
Yes, I've had manufacturing failure. It's very frustrating from a provider and a patient standpoint. My personal bias is if I have someone who has rapidly proliferating tumor, I think my confidence in the axi-cell manufacturing will choose me to choose that therapy. So for the instances where I've used Tisacel or prescribed it, it's been in situations where patients have low volume disease. They're clinically stable. Again, I've had at least one situation in that setting where I had a patient that failed manufacturing and we just attempted a second attempt, and the second attempt was successful. It just adds to your manufacturing and your lag time about 3 to 4 weeks.
Mm-hmm.
Yeah, I think it's important to have expanded access programs for these CAR T cells, which both commercially available products do. You know, we're one of the sites for Zuma-9. So if it was an axi-cell manufacturing issue, then potentially the subject could go on to Zuma-9 and potentially still receive their product. And the same thing does apply for T600 like Lucil. And we have that open also.
So that would be an out-spec kind of product. He can still give it, but
right.
if you don't have
manufacturing failures, I don't think we've had that scenario, to my knowledge, come up.
I've had two actually on the Tisacel kind of patients that failed manufacturing. We were advised that the second attempt of manufacturing would be more successful than the first one, but I didn't want to take a chance. Therefore, I went for Yescarta, and actually the two patients received very good cell quantity and viability, and they worked very well. So that's my experience with failure of basically manufacturing. Nothing with the Yescarta, but more of the Kymriah, as you would know. So any trouble or experience with trouble with infusional reactions or any kind of situation that you think you want to share with us about infusion, Loretta?
One of our first standard of care patients, within a few minutes of infusion of the cells, had what appeared to be an anaphylactic reaction. And again, this was early days where we were all learning, and so tocilizumab was pulled immediately, but I think it was more of a reaction to the preservative that the cells were frozen in, and maybe a different approach might have been used. The patient did well, but since then we've had training and recognition. Again, one of the things I think is unique about our center is we're not stem cell transplant physicians, we're lymphoma doctors, and so all of you who are transplanters are probably more prepared for those rare instances that might occur. But it's the only time we've ever had a reaction or any sort of adverse event during the cell infusion.
Yeah, the DMSO reactions that you're more accustomed to in your your rare auto or allo situations, definitely, even though I think it's less of a concentration, but those reactions are so unpredictable. Yeah.
So we're going to move to a second case, and I'm going to tell you about this case, and then we can discuss it a little bit. This 61-year-old farmer referred to our institution for evaluation of CAR T therapy. His past medical history, rheumatoid arthritis that's controlled on a low-dose methotrexate. He was diagnosed with relapsed refractory diffuse large B-cell lymphoma, CD5 and MUM1 positive, ABC type. Unselected lymphocytes were collected uneventfully. Cells were shipped to the manufacturer and unfortunately didn't grow, so failure of manufacturing here. due to fast disease progression, we had to actually suggest bridging chemotherapy for this guy. So with the situation now that he doesn't have cells and he's progressing, and hopefully we're gonna try to get cells from him again to try another attempt for the manufacturing. So becomes the problem here, what kind of therapy that you can recommend for bridging without having to compromise the lymphocyte collection. Loretta?
Yeah, so again, our practice patterns have probably evolved pretty rapidly just recently. What we had been doing prior to the FDA approval of polatuzumab was hypercytoxin in combination with dexamethasone and a CD20 antibody, mostly just as a stabilization method. Recognizing that, yes, that is going to be cytotoxic, particularly to T cells, since it's also used in lymphocyte depletion. But it's just something that our institution was very comfortable with and our inpatient nurses were comfortable with. What has evolved recently is the introduction of more targeted therapy, as you mentioned here, either R-squared or ibrutinib combination strategies. I would say we're doing that more frequently in the non-GCB subtype, again, just based off of our institutional experiences. And then now with the introduction of polatuzumab in combination with CD20, that has been a strategy that's been used more recently. The whole discussion surrounding bendamustine, oftentimes we're omitting bendamustine till after the cells have been collected and then introducing it for at least one cycle, again, to try and stabilize these patients prior to infusion.
Yeah, I agree. ABC, I'd be thinking R-squared or ibrutinib. There is data kind of with ibrutinib kind of leading into the, leukapheresis and kind of may be advantageous, but that's, I think, going to be bore out in clinical trials and is being investigated. With regards to the polatuzumab BR, I think that, we probably won't be in this situation before, but there were times where polatuzumab BR was approved that people had already seen BR. And so we were kind of forced to say, do you withhold a drug that's novel in its class to this patient population? And it's kind of not right to give a drug that they've already progressed on. So that kind of led you down the path of giving polatuzumab as a bridge before apheresis or as bridging. And I think that would be, it's an approved drug, and I think that would be a reasonable approach. And I think I struggle with the GCBs. I've given dose -1 epoch before, just in those fast coming in, hot growing lymphomas, just because I believe kind of the infusional component may be different than the bolus component of what they've seen before, and you're unlikely to see the kind of the anthracycline toxicity from a cardiomyopathy standpoint, even as you get higher dose accumulation.
Great. So the patient, as you've seen, had R-squared successfully that temporized the lymphoma from progressing at least rapidly. We were able to recollect and manufacture the cells. Then he was infused after the second manufacturing. His complications included grade 2 CRS and grade 3 neurotoxicity. So I think, Matt, you can tell us a little bit about your idea about bridging therapy, a little bit more details about what you're going to use and what's your preference.
Yeah, I think that, from my standpoint, bridging therapy, I try to break it down into kind of those that are obvious or early bridging. I do lean back on their cell of origin to help guide potentially if they're going to get ibrutinib or R-squared. I just don't always have the confidence that R-squared or ibrutinib is going to be able to maintain those people who have rapidly proliferating disease, regardless of their cell of origin. I may incorporate it as part of their therapy, but I may be looking for more intensive chemotherapies, and so then you're starting to get into your gemcitabine-based regimens or your BR polatuzumab, with all the caveats of kind of trying to hold off bendamustine. But, if it's the difference between, getting them to CAR T cell versus not in rapidly progressing lymphomas, I may choose to give the bendamustine because at least you may get them to an apheresis time point. And I guess bridging therapy has taken a new name because bridging therapy is, meant to, in my mind now, when you want to do CAR T cell to when you're infusing CAR T cell. So there's actually that therapy that may exist in the brain to vein time. So when you want to do therapy between apheresis. And in that situation, you may want to use the same therapy. I also look at it from a late therapy standpoint. So if there was an intent, you felt the disease could wait, but then it can't, then other options include high doses of steroids. I've used Dex 40 times 4. The other thing that comes to mind is often radiation could be used kind of in a boom type of a fashion to kind of control dominant sites of disease. So you understand it's a systemic process, but there may be one disease site that's not behaving like the others, kind of a Sesame Street lymph node. And in those regards, employing your radiation to kind of tame that site for some allowance of time, especially if it's encroaching upon organ function that you need to proceed. There are some therapies that to consider avoiding. Checkpoint inhibitors, I don't think has a lot of data kind of going into the kind of the pre-AIF, post-AIF, and what that would do to energize potentially the T cells. And then also blinatumomab, which is more specific for our ALL experience, but from a targeting CD19, there isn't a lot of good data in lymphomas about how perturbing the CD19 molecule pre-CAR T cell may affect the efficacy of CAR T cells in the lymphoma setting. I'd imagine with tafasitamab data coming out, that's a CD19 antibody. That question we're going to have to deal with moving into the future.
Loretta, any addition there?
No, I completely agree. I think particularly as tafasitamab starts to move into earlier lines of therapy, that poses a whole discussion about earlier introduction of CD19-directed therapy and what does that do in terms of CD19 expression or CD19 loss. I think that will be an interesting discussion to have. But as that option becomes available, again, particularly if you're running out of options and you need someone that you need to keep alive, 1, and 2, you need to adequately control disease to try and mitigate some of their toxicity as well, I think we're open to all options in these patients.
Great. Matthew, you're going to take us through some of the slides here, so please go ahead.
Yeah, so the next slide is looking at response rates were consistent across ABC and GCB subtypes, and you can see here that all the way down, kind of ABC, there were 17 patients, and GCB 49. The CR rates and overall response rates were fairly equivalent. And so when it comes to kind of what we've seen in CAR T cell therapy in general, the CAR T cell doesn't care if it's a double hit. It doesn't care if it's it's a GCB or an ABC. It has the opportunity to get a person into a remission, and that remission may be durable. So kind of moving into the next discussion about that case 2 had some acute toxicities related to CAR T cell. We had commented on an infusion toxicity, which is likely not necessarily it may not be due to the CAR T cell, but maybe due to the preservative. We also discussed that there may be some highly proliferative tumors, and so tumor lysis syndrome can occur, especially with as effector cell expansion occurs, and so that being monitored. And these patients are often inpatients, and so and you're treating that concurrently as the patient's being treated. CRS is defined as a superphysiologic response to any immune therapy that results in activation or engagement of endogenous or infused T cells. We see this often manifested first and by definition has, at least with the ASTCT guidelines, has to have fever first, but then kind of a capillary leak phenomenon where you get hypotension and hypoxia. Next is immune effector cell associated neurotoxicity syndrome. This is a smorgasbord of different neurologic complaints. In my opinion, it could be, often I see it starting as a tremor in the hand, even though if it may not be defined by the ASTCT guidelines. But I'm often, back in the days when we could shake our patient's hand, now I would shake their hand to see if I feel a tremor, or now having them hold out their hands to kind of see. This is often defined now by the ICE score. In adults, the kind of a 10-point scale, which is a little bit easier than the MMSE. Cytopenias can be seen both in the setting of macrophage activation syndrome or HLH, but this is very rare and severe, but can kind of masquerade as severe CNS. You can also see B-cell aplasia as an on-target effect for CD19 CAR T cells, which secondary causes a hypogammaglobulinemia, which may be persistent for some time. The ASTCT met as a group of individuals, CAR T-cell experts from all over the country, from different institutions, and their goal was to provide a uniform consensus grading system for CRS and neurotoxicities associated with immune effector cell therapies. And as you know, and from our previous weeks, different clinical trials use different grading systems. And so, while we shouldn't be cross-comparing, we often try to, but you have to remember that these are, these trials that we're discussing are all apple trials, but they are different types of apples. So this guideline was published, and I think a lot of centers have went on to adopt this, and a lot of clinical trials continue to try to adopt this. So here are the principles of toxicity management. I think we can spend a little bit of time on this because I think that this is truly in evolution in real time as we kind of continue to be in the commercial environment, but we are being informed by later and later and cohorts of clinical trials from the previously published trials on how to mitigate toxicity without the hopeful mitigating too much the toxicity that you affect efficacy. So you can see here often with grade 1 CRS and neurotoxicity, you are providing supportive care. As you move into the higher grade toxicities and CRS, tocilizumab may be used. Neurotoxicity, often we employ steroids and tocilizumab use. In the setting of pure neurotoxicity without any concurrent CRS, steroids would be used. But if there is concurrent CRS and neurotoxicity, tocilizumab and steroids could be used. As you march into grade 3 and grade 4 neurotoxicity or CRS, you start to use high-dose steroids and tocilizumab, or neurotoxicity, you're talking about significant high doses of steroids with the hope that the patient turns around. If there's no improvement, despite a couple of days of very high-dose steroids, then other measures, which are often driven by institutional thought processes, are used, or clinical trials. It's important to always rule out alternative causes. If tocilizumab is refractory, then consider steroids in that situation. For people who you appear are going to be on steroids for long term, as if you were tapering very quickly and they have recurrence of their symptoms and they're going to be on high-dose steroids for a long time, considering fungal prophylaxis, I think is important also. So here are kind of looking at the CRS and neurotoxicities from the approved CAR T-cell therapy. So Axi-cell reporting out in ZUMA-1 and Maraleucel, both in Juliet and Ileana. You see here kind of across that, again, that these were different toxicity grading criteria in the Lee and then the Penn grading scale. You can see grade 3 CRS in ZUMA-1 was 13%. In Juliet, it was 22%, and in Ileana, it was 47%. Again, different criteria, so these are hard to cross-compare, even though one may be higher than the other. In regards to grade 3 neurotoxicity, you can see in Axi-cell was 28%, and in Maraleucel 12% and 13% in Ileana. If you look at tocilizumab use, often for CRS, 43% of the patients with Axi-cell had tocilizumab use, but had 13% grade 3 CRS. So again, how the clinical trials are run often define kind of what you use. And so if you're using it earlier on, you may have a higher percentage. So this is just looking at some of the mechanisms of neurotoxicity. We talked about CRS, kind of can look like a capillary leak syndrome. Often this can lead to endothelial permeability. So as you see increasing levels of systemic cytokines that were found when you assess the cerebrospinal fluid, this is likely, you can see the CAR T cells in there, but this graph, cartoon at the bottom is showing before infusion, and after infusion, you're seeing increasing interferon gamma as well as IL-6 levels during, not only in the serum, but also in the CSF, which is likely driving the neurotoxicity. So with that, I'll kind of pose the question to the group that institutionally, how are you guys changing your toxicity management? Are you sticking to the clinical trials? I know we all have REMS programs in place. Loretta?
So we were pretty quick to try and develop our own, and that was the Toxicity. And we have an app even that is widely used by our inpatient teams, including our nurses. And you've highlighted some of it, but I think the most important thing is you need to be able to grade it quickly. And then your management strategies are going to evolve over time. But as long as we're all consistent on what a grade 2 CRS or neurotoxicity is, I think earlier strategies to try and reduce them from transitioning on to grade 3 or higher are very important. There will be consensus, just like the consensus on grading coming out regarding management. I think that will help, but I also recognize that this will also evolve over time. So though we all have our own institutional preferences, I also know not to be too married to them, because each time I'm on service, I have to relearn what's changed from the last time I was there. But I think earlier identification and strategies to reduce particularly severe toxicity is where I spend a lot of time and effort.
So we use in our institution the conventional way, as you showed exactly. However, we have a trial going on difibrotide and CRS medication, and I think we're putting most of our patients on it for Yescarta. This sounds like going to be a little bit promising. But I can tell from before and now that we have been really much more comfortable using steroids a little bit earlier. To try to sort of mitigate the side effects. And, you know, at the beginning, we were really scared to do that, but now it's much better. So that's what we were doing.
All right, Loretta, I think I'll let you take over here.
Yeah. So again, there are strategies that are being explored right now to try and reduce toxicity further. And I think particularly the grade 3 or higher CRS and neurotoxicity, because I think that's the one area that if we could improve upon, you could potentially do more outpatient infusions, which again might be more financially feasible. So one specific strategy that's being looked at right now are 2 prospective studies, and we have even a pilot study at our own institution looking at anakinra, which is an anti-IL-1 agent. If you look at the cytokine profiles, we know about tocilizumab and maybe even siltuximab that blocks IL-6 or blocks the receptor that IL-6 may act on. But if you look at it, IL-1 is even an earlier rising cytokine. So again, strategies that may mitigate that toxicity before it progresses, particularly to those higher grades. We won't talk about this too much, but there have been strategies looking at prophylactic tocilizumab, particularly with Axicell, and though it clearly reduced the rates of grade 3 or higher CRS, really had no impact on the significant neurotoxicity. And numerically, you could look at it and say, if anything, maybe slightly higher rates. So again, if you could potentially block other cytokines earlier in the development, would that therefore reduce the risk of grade 3 or higher neurotoxicity? And anakinra might be one of those strategies. Recognizing that it's been used in autoimmune conditions for a while now, risk of infection is the one concern. And again, recognizing these patients have all had lymphocyte depleting chemotherapy will be higher risk for infection. I think those are things that need to be considered when introducing these agents, particularly as prophylactic strategies. Another potential strategy is to try and target non-T cell or non-cytokine specific strategies or methods for toxicity. And one such strategy is using GM-CSF to target macrophages and granulocytes, again, as a potential strategy to mitigate some of the toxicity that's being driven by other myeloid cells. Again, we have some potential data in our center that some of these cells might be equally important in driving some of the neurotoxicity. So this is a trial that we will be opening soon at our institution, again, looking at GM-CSF as a mitigating strategy, particularly for high-grade CRS and neurotoxicity. You've heard that we're all more comfortable with earlier use of steroids, and this was a cohort of the ZUMA-1 study. It's called cohort 4, which was a non-randomized, really just a safety expansion to look at earlier use of steroids and again on the mitigation of CRS and neurotoxicity. So patients had steroids intervened at grade 1, cytokine release syndrome or neurotoxicity, as opposed to waiting to grade 2. And again, that evolved initially. Early in the study, we only introduced these these agents with grade 3. So you can see sort of the natural evolution is to start to use this in earlier time points, particularly when we're trying to mitigate the development of higher rates of toxicity. Again, the concern would be that you might be also having a negative impact on efficacy, and what's demonstrated here, albeit relatively short follow-up, the patients who were treated in cohort 4, though non-randomized, look to have similar efficacy as defined by duration of response in comparison to those who had steroids used at later grades of toxicity. With that, I'll kind of stop and pose this question to the group. One of the things I struggle with when I'm on service are those patients who've had grade 1 CRS, which is primarily just persistent fever that's been ongoing for 72 hours despite all of the supportive measures such as Tylenol, sometimes even NSAIDs, cooling blankets. And I think mostly our nursing staff and family members start to get particularly anxious about those situations. Are you intervening at that time point to try and stop the CRS, Matt?
I think Zuma 1 cohort 4 kind of gave us that window to actually treat those patients. And I think that that's been part of our discussion at our institution, is whether or not to adopt the risk mitigation or the treatment strategies that were employed in Zuma 1 cohort 4, and I think that we were in favor. We want to see longer efficacy data, but we also agree with you trying to mitigate those 3s and 4s. It's very interesting though. It's very not very often that you get that scenario of 3 days of grade 1. Often it's kind of day 1, grade 1, day 2, grade 2. So you're already there.
And Matt, one thing I wanted to just ask you about with your second case, you mentioned this patient had rheumatoid arthritis and was on methotrexate. So that's another topic that we debate pretty regularly, particularly in terms of risk of HLH or severe complications of CAR-T. What are your thoughts on patients with active autoimmune disease going into CAR-T?
It's a concern for sure. I mean, I look at it with the management of the rheumatoid arthritis or the autoimmune disease. If it's just a simple management using steroids or using methotrexate low dose for a long period of time, I think we can pass on these patients. However, if somebody having uncontrolled autoimmune disease or requiring disease-modifying agents, I think I would be very scared to put them through the CAR-T.
Yeah, I think a CAPS patient or a lupus patient, may be different than, but I mean, I think we're talking also about, a potentially therapy that could have long durability with, we don't have a good experience. And I think that would be actually a real world experience that would be worth looking at, is kind of CAR T-cell in patients with underlying rheumatologic conditions, that, because they're not going to be represented in the clinical trials.
Right. One other topic here before we move on to our last topic of discussion, which is failures. This was data presented by Jeremy Abramson at ASH this year, looking at the Transcend study, which was the phase 2 trial looking at the JCAR, which was a 4-1BB anti-CD19 construct. One of the things that was slightly different about the study population is, though they had a sort of a pivotal group that they tried to match in terms of characteristics similar to what was seen in Zuma 1 in the Juliet study, there were a number of other sort of subtypes of lymphoma that were treated with the JCAR construct. But also the toxicity, again, recognizing different scales were used, but did appear to be quite favorable, with any grade CRS being at 42% with later onset, with median onset of 5 days in comparison to particularly Axi-cel, and the neurotoxicity, any grade 30%. When you look at those grade 3 or higher CRS or neurotoxicity, again, small frequency, so 2% or 10%. The use of things like tocilizumab and steroids was 7 or 21%, and 13% used both. Again, maybe a more favorable toxicity profile, but an agent that, at least with about 15 months of follow-up, had an overall response rate that looked quite comparable to what had been previously reported with Zuma 1, with a CR rate of 50%. So again, Matt, are your thoughts that toxicity might be overcome with construct, or is it construct and management strategies?
I think it's a little bit of both. I think the construct may have something to do with it, but it also, comes down to how the protocol was written and how you managed the patients and what you actually called what you thought it was. And these trials lasted over years. And so again, kind of what was at the beginning often is the question is it the same in the fourth year of the study? And you try to do the studies the way the studies are written, and I think you do your best, but you can't help to learn kind of through the lifespan of the studies. And I think that applies to Zuma 1, Juliet, and likely Transcend. So, but I think one thing is clear is that there is a difference in the later onset, day 5 with a median of day 5 and for CRS and neurotoxicity at day 9. So I think that's the most glaring difference. The grading, I think, is always going to be an issue, and these were not graded on how we're grading right now.
Mm-hmm. Ahmed, what is your impression of the Transcend data? You were overwhelmed. Okay, so we'll close up. We're talking about patterns of failure. So why is it that 60% of patients really just don't have meaningful outcomes with CAR T-cell therapy? So this was a graphic that was included in the New England Journal paper looking at, well, what are the reasons patients fail? When did they fail? Looking at the Kaplan-Meier curve. And again, some of those that just never respond, or those that actually achieve a response but then go on to fail. And I think those, to me, are some of the most frustrating situations, because we put so much hype into this. Is it potentially being curative therapy for patients, some of whom have never achieved a complete response? They get that complete response early in their response assessment and then lose it over time. So again, there's a number of studies underway to try and identify strategies, and that will be a topic of discussion for next week. But Matt, what are your thoughts about these failures and how you potentially might address them?
Yeah, I think the biopsying is first off. I'm looking for what was the escape mechanism? Was it PD-1? Was it CD19 antigen loss? Or then there's going to be that box of unknowns that we aren't going to figure out why. You like to think that you're driving your therapy, your next therapy, but it's also helping kind of you better understand the disease process. So, to the next slide, but that's kind of what I think that prior cartoon is kind of similar numbers to what I had in my head. But I think biopsying is important to kind of figure out what to do.
I agree. And then Ahmed, any closing thoughts about sort of why patients might fail CAR T and strategies that might overcome that?
So the a clone comes out without the target that we targeted. Basically, CD19 becomes a clone that's CD19 negative, is another way of relapse post-CAR T. I think the difficulty here that we don't know exactly which therapy will work, but biopsy, as Matt said, would be very important. I actually biopsy every patient relapses post-CAR T and then decide based on that what kind of therapy we can give them.
Yeah, I agree. And so stay tuned next week, because we'll be discussing that in much more detail.
Great. Thank you all. So we will open it up for questions now. If you do have questions, please make sure to submit them in the question box on the right part of your screen. So we do have one in there right now. So let's see. So there's going to be some data from CIB MTR analysis presented at ASCO this year. So the question is, will the use of CAR T in PR or VGPR, will this be impacted based on that analysis? So are you familiar with this? And if someone would like to answer that question.
Yeah, I'm familiar with the abstract. I believe it was from the MCW group that used the CIBMTR database to look at PRs. I believe there was a similar paper that had been done before that. I think CABMTR is a good resource. It kind of gets to my point, though, that that's a self-reported institutional response. And so you have to trust that the person who's the institution that's putting in the data saying that it's a PR is truly a PR by the criteria that was used to be a PR. So, kind of over all of that was it CT based or was it PET based, and and in what era was these PRs put in? I think that there's truly VGPRs, and I think that there are less than PRs, which are probably stable disease when it all comes down to it.
Great.
But yes, I know what the data shows, and I think that kind of gets at the outcomes of that is still controversial on, that was taking all comers often, and I think they looked at early relapses versus late relapsers, and the early relapsers were felt to do, at least in that series, as good as the late relapsers from I think it was a 5-year PFS in the abstract.
Great, thank you. And then we have another question. So what is the status with allogeneic CAR Ts? Are they another option?
So the allo CAR Ts are currently under investigation and you'll see some trials in progress reported at ASCO. But that's one potential strategy to overcome patients who've had multiple lines of therapy and improve upon T cell function or fitness. The concern and what needs to be demonstrated in the studies is whether or not using someone else's T cells will lead to the persistence that's necessary to generate the efficacy seen with the auto CD19 CARs. So potentially younger, fitter T cells that are maybe even off the shelf and ready to go within 1 to 2 weeks, but persistence will be the question.
And I think that with the allo CARs, they'll be able to do some different tricks than that you couldn't do necessarily with an autologous CAR, just because of timing wise. So that would be the other thing that may be more maybe attractive to allo CARs, is what you can do to manipulate the switches, the extra sparkly stuff that may matter, may not matter.
Great, thank you. So that appears to be all of our questions for tonight, and we look like we're at the end of our program. So just a huge thank you to our faculty for taking the time to sit down with us this week. Thank you to our listeners, and I truly hope you are able to gain valuable insight tonight on CAR T-cell therapies. So you will be able to listen back and watch this webinar shortly following. You should receive a link. So tune in next week. We'll be back for our fourth week with our panel. We will be discussing what's on the horizon, so some of the new therapies. I know they were mentioned off the shelf. There's different targets that are being looked at. So we'll be talking through some of those. Continue to visit oncolive.com. Sign up for our e-newsletters or follow us on social media, on Twitter, LinkedIn, and Facebook to get updates. Also, you can visit oncolive.com to sign up for the webinar for next week as well. So that concludes our webcast. Thank you, and have a wonderful night.
Thank you.
Thank you.
Thank you.